It's my pleasure to introduce Dr. Amy Noland. Dr. Noland is an assistant professor of emergency medicine at UT Houston and the assistant director of the UT Emergency Medicine Global Health Fellowship. For her talk, she will be discussing emergency care and training in resource-limited settings. So welcome, Dr. Noland.
Hey guys. Well, thank you for letting me talk today, and I was very excited to tell you what we're doing in the Department of Emergency Medicine at UT. And if you have questions during the talk, please feel free to raise your hand. It's pretty informal, but there'll be some time at the end also. So the team within the Department of Emergency Medicine is pretty small, but we have some neat projects going. It's headed by myself and Rohith Malia, who's faculty. We have a resident vice chief, and starting in July, we have our first global health fellow who's coming in, which we're really excited about. So the way that we have structured our program and the reasons behind all this, I'll tell you as I go through the talk, but our approach is to take very few select sites and really focus on those, with the goal being that we have, if we can't have a continuous presence, a consistent presence. So often, many months of the year there will be a resident there with faculty supervision for part of the time, and also medical students as well. And this allows us to do part of our other goal, which is to create long-term research sites. So the fact that we have these consistent presence in these places allows us to develop things, especially in the acute end processes of chronic disease, which I'll talk a little bit later in the talk. And it allows research opportunities for our residents and medical students and faculty as well. And we are academic institutions, so always it's our goal to create a good learning environment for our rotators and others. So when we started this program at UT a couple years ago, and the big question was, what can global health do for us, right? So, a lot of our residents often are regaled by stories from our faculty of the good old days when they trained, and you never saw a faculty member, they were napping in the back, and we ran this place and we made all the decisions, and those days are gone. They're not coming back. But the way everything is structured now, and with quality assurance as well, you're not going to have that just license to figure it out on your own anymore. And for most reasons, that's good, right? And residency is it's a short time. It feels like it's getting shorter all the time with all the hours restrictions, and it's a limited opportunity for the residents to have, trained people with more experience than they have, guiding them through their learning process. But that being said, it is an important skill to learn. It's how to make your own decisions, how to develop your own practice and all that. So this is a place where our residents have found they really get an opportunity to do that, and a place where otherwise there wouldn't be a doctor with any emergency medicine training, or any doctor at all. And so hopefully the patients are faring better, and our residents are getting that experience as well, and the medical students too. And so acute awareness of resource-limited limitations. So we practice mostly in the medical center, right? And we have every resource at our disposal. And usually that's great, and it's wonderful for our patients, and we can provide for them in ways that we couldn't provide in other places. But we've all seen, that CT scan order that probably didn't need to be done, and you get the basic labs, and you realize that it completely did not change what you were doing for the patient at all, and now they have, radiation exposure and a $15,000 increase in their bill. So just because we send them through the truth machine, right? So when what we find when our residents come back and they've been practicing with limited access to a single slice scanner, or the closest CT scanner is 4 hours drive down the road, which is the case in one of our sites, that they are thinking more about, do I really need this? Is it going to change my management? Is it going to benefit the patients? And the same for labs, et cetera. So disease without borders. So we've all seen, if you've worked in the county here, you've probably seen that rare Chagas case that comes through and everybody goes and grabs everybody else, or the advanced TB or POTS disease. We've diagnosed a few of those. But it's not just this, right? So it's not just the traveler who comes back and has been in Africa for business and he has a positive malaria smear and we've solved it. It's also, there's documented cases of dengue now that have, and people who've never left Florida. So it is global medicine now. It's everywhere. We have all these plane flights. The mosquitoes get on them as well. And so, we need to learn, and it behooves our medicine here as well to learn how to diagnose and treat these maladies. So ability to relate to patient populations back home. You know, we do still have some almost developing world medicine in Houston. Anybody who's aware of Harris County's compassionate dialysis program knows that. But, you know, being in a situation where you have the same access that your patients do to medical care, that if you get sick in the jungle, if you get injured, you have the same access. You're gonna have to solve the same problem and get yourself treated and get yourself out of there. And that kind of gives a new perspective for a lot of people who go over there with us, we found. And I had a patient who came in, she had this raging fever for 4 days, it was 104, she was very ill, septic, and I'm trying to treat her and sort of gently chiding her and trying to teach her for the future, saying, you know, you're really sick, and if you'd come in when you first got your fever, you know, this would have been easier to treat and you would have felt better and all this. And she said, well, you know, I mean, I got my fever, and so then I walked here. It took her 4 days to walk to where she was getting the care. So, you know, it lets you look at things in a new light, the barriers that people have to getting care. And exchange of best ideas and practices. You know, it's tempting to think that we know everything, we do everything the best, we're in the biggest center in the world, this is, you know, and that's definitely what we should all strive for, but there are many things that we have lost sight of or that we've never had to develop. You know, our residents and medical students come back with much improved physical exam skills. People who work on in a regular basis without the access to the advanced imaging we have to rely on those, and they come back feeling much more confidence in those skills. There's a surgeon who works at the one hospital in hundreds of miles, this area in Thailand, who's been there for 30 years. And there's a lot of leprosy in the area, so he's developed all these surgical treatments of like rerouting the FDP to give somebody an opposable thumb, or rewriting the masseter to let them blink and save their vision. And not that we're expecting our emergency medicine residents to do any of these procedures, but you know, he also does all of his surgeries, XLAPS or FFemur, all of this with spinal anesthesia. And so, you know, they get much better at spinals, they get much better at doing all these procedures that normally, you know, they aren't as good at. And it's a humanitarian effort. I mean, everybody who's at this conference knows that, and there's a lot that you get out of giving your time and your effort. So, you know, ask not just what global health can do for you, but what you can do for global health. So why emergency medicine? Why is it well suited for this? You know, what's the adage about emergency medicine is that you need an ocean of knowledge half an inch deep. And, you know, some of that is true in the sense that it's helpful when you go to these places to have, you know, a knowledge of child delivery and, you know, some of the complications, to know how to treat a STEMI with thrombolytics, to know how to identify and treat a stroke, et cetera, et cetera. But, you know, the way our specialty is built, it's not like a pediatric, you know, cardiology surgeon who can go to an underserved area in Russia and, you know, everybody knows in advance that they're coming and they can do a lot of surgeries, do a lot of good in a short amount of time and leave, but they've done a permanent and lasting change. You know, we deal with acute end processes of disease, and so we're like, hold on your STEMI, just wait for your stroke, we'll be there in a few weeks, and, you know, don't get really septic until we get there. It doesn't really work, right? So this is why we pick these small, just the 1 or 2 sites, so that we can, with our consistent presence, we're changing the paradigm of medicine is what we're trying to do there. So in these settings, you know, in our Burma site, there's some medics who are training, and people with very limited medical training have huge medical responsibility. They're responsible for everything that happens. Anybody that gets sick, they have to make the decision, you know, can I treat this? Are they, you know, is this gastritis? Is gastroenteritis? Is this appendicitis? Do I have to load this person up on a 4x4 with a stretcher in the middle of the night and take them 4 hours down the mountain to the one surgeon and 300 miles? Or can I stabilize this person here? Can I act on this here? And so all that sort of diagnosis and triage and question of whether or not to transfer is something that our specialty is suited to address with them. So all of our second year residents, it's a 3-year residency program, all the second years have an opportunity to go if they're in good standing and, you know, pass their in-service, all that stuff. And we also have rotations for MS4 students as well. And I'll get to the sites. So this is the first site that we started at. And so it's the Kwai River Christian Hospital on the border of Thailand with Burma. And I mean, talking about resource limited settings, you know, they're making their cotton balls that they're gonna use as well. This is the operation room, the one air-conditioned room in the hospital. And you can see all their shoes there because we don't have shoe coverings, right? So they just operate barefoot, so that it's more sterile than tracking everything in. And our residents get a familiarity with it. These are all the IV drugs they have in the hospital. And people show up and salbutamol. I'm not really totally sure what it is. I think it's like albuterol, and they, get used to that. And this, I just thought was funny. They have no blood bank. They have no ability to, their power goes out often. And so the surgeon that I mentioned before, he happens to be O negative. So he'll just operate usually on the patient. And if there's no family member to donate, he'll just go donate the blood and, give it to them after he's finished the operation. So they'll take, blood for any covers. And I just thought this was funny. I was like, oh, I've got some blood, I'll give it. And they're like, oh, yeah, what's her name? Like, no HIPAA. They're like, what's your blood type? Okay, we'll trust you. It's cool. I was like, oh, check it, please. So this is an example of, this is a nurse's aide, and she's the one diagnosing and treating this patient with acute glaucoma. This is, if you're familiar, if you've seen the tono pens, this is what they developed from. This is the tonometer, and so she's using it to diagnose. And here, a medical student is helping her and learning from her as well. But this is where people with a little training have a lot of responsibility in how we can help with education. And, just examples like this is a family that walks, 3 days to bring her husband in, and, families want to stay with their loved ones as well. So she just slung up her makeshift crib, and the baby's sleeping next to dad, and she's cooking in the hospital on the floor next to everything. So just some of the local people this is supposed to wear off mosquitoes, and it didn't really work in my N of 1, but it's attractive. And so disease without borders. So this, does anybody know what this is? Right. So they use this on the right. This is a tourniquet test was the answer. It's a way to check for capillary permeability and low platelets, and somebody who with dengue fever who is or is on the verge of hemorrhagic fever. So, and this is somebody who's come from close to actually one of our other sites, but somebody who fell out of a tree 2 days ago. His friend made a splint for him and then carried him from the edge of Burma, and he had compartment syndrome. So this after relief of the compartments, but our residents got to participate in as well. And there's one of them doing an LP with like the gecko that's up against the wall there. But and also, so none of our residents or medical students really knew how to treat TB or how to read the chest X-ray, what therapy to start, how to follow it, and all these things. And these are ways that we can learn when we go over as well. So we're moving more towards Burma. In this area, it's a carved out area of the Mon people, who are sort of persona non grata in the Myanmar state. But there were warring factions that went on for a long time, but so they've basically had this area carved out for them by the Myanmar government, and it says, you can stay in this area. We will give you no support, no food, no medical care, nothing, but we won't bother you if you stay within these borders. So they're just hanging out in this area in the jungle, and they have virtually nothing. So this is their hospital, and you can see like scant mosquito nets. It has power for a couple hours a night from a generator, and this is where you're doing your own blood typing and spotting, your own malaria testing. And this is one of our fourth-year medical students who went in between. She's now an intern with us. And she was doing a rotation there and got woken up in the middle of the night because somebody had an accident. And she is sewing up his puncture wounds to his chest wall and then diagnosing his pneumothorax, which she then got a chest tube for. So she's doing it by the light. And this is something that, nobody there had any idea how to do, but now they've seen one. Now they can hopefully be able to do one in the future. And she'd seen one. This is the see one, do one, teach one. When she was a resident, a medical student, had never done one, and so she's getting that experience as well. So and that's just her exercising with all the students. But this is sort of to give you a picture of the area that we're in. This is the main city that's about 40 miles from where you just saw, and this is the gas station along the corner, which I love. You can see the liter Pepsi bottles to fill up your petrol, etc. Local temples, and we don't have a lot of time for all this, but this is the market. You go once a week, and we let, whenever we have our everybody go over, we don't expect you to fly halfway across the world and not see anything. So everybody they'll go on an elephant ride, they'll get to go to the temples, they'll see a few things. So we want them, people to get life experience as well. And it's not a bad place to visit. So Fiji, this is our other site, which is very different. So in terms of just basically a hut in the jungle, which is what Burma is like, this is an area that has some money, that has started to develop their medical care, but sort of in fits and starts and partway here and a little bit way there. They started their first emergency medicine residency program this year. So this is a bunch of doctors who could get the same jobs they have now working in the ERs for more money if they weren't residents. So just like emergency rooms here before emergency medicine was a specialty in the States, they're staffed by family practice, internal medicine, surgeons, et cetera. And so but these doctors wanted more experience. They're either recent grads or some of them have been doing it for 20 years and they wanted to learn more. So they took a pay cut to keep the same job to join this residency training. And they will, when our faculty fly over and are doing lectures and our residents are doing lectures, they're spread out over 17 islands and they will work 30 hours, get on a plane, get on a bus, go over to get lectures and then go back and work. I mean, they are motivated doctors, motivated learners. So the main site in Lambasa, that's the landing I'll show you, but the acute and processes of chronic diseases is really where we're doing a lot of our focus and research in Fiji. So, when people all over the world start to live like Americans, they start to die like Americans, and they've adapted the Fijian diet in general is, if possible, worse than the American one. I mean, everything is deep fried. And what they've, imported is McDonald's. So it's just compounded an already existing problem. It's really not unusual to see 30-year-olds and 40-year-olds come in with STEMIs, with devastating strokes. And there is a cath lab in Fiji, in the main hospital, that is open 2 weeks a year when the New Zealand team that built it comes in to operate it. And if you don't happen to have your heart attack in those 2 weeks adjacent to this hospital, you're kind of out of luck because nobody is treating with thrombolytics at all. So that's been one of our major goals in the area. My colleague just worked with the national pharmacist. They've made a large order of streptokinase. We also have TPA for stroke. And so a lot of what we're doing when we go over there is educating how to diagnose an ST elevation MI and how to diagnose a stroke and what the criteria are for giving lytics for either one of those conditions. And getting over the resistance that's there of, the perception that, if you give somebody lytics, you're killing them, which is, difficult to overcome. But we started to get success and people are, the emergency residents are starting to work with cardiology there and neurology, so it's hopeful and it's pretty neat. So this is one of the EDs there in Lambasa. It looks sort of like a Meineke car care center to me, but it has a pretty nice view at the front. This is one of the resuscitation bays, and this is their ECG. So if you've done global places, a lot of places have this. We don't have the fancy stickers, et cetera. And there's one of these on the entire first floor of the hospital, and there's one somewhere upstairs that's been broken for 12 years. So you can see sort of a challenge the way we practice of serial ECGs and looking at somebody's heart in time and comparison, or a screening ECG for somebody having chest pain in the waiting room. Do they have to come back? Do they not? All of that becomes very challenging when this is your equipment and there's one of them in the hospital. And that's the leg leads. So our residents, you can see, I'll tell you about some of their experiences there, which have been great. We carried an ultrasound in a backpack over there. And in fact, if anybody who works for the Mobic that has the handheld one, it's really nice on the smartphone, and they want to donate one, I'd love to talk to them because I still have back pain from carrying this thing to Fiji. But it was really great. We got to show them how to use it. They're planning on buying a few ultrasounds for their ED. And this is a gentleman who, the patient had a large piece of bamboo stuck in his arm. And we had difficulty convincing the surgeons that it was there because it wasn't showing up on x-ray. So the patient, we'd told him that they had it, he'd gone up to surgery and they had made a small incision, didn't find it, and they were gonna sew him up and send it back. So the patient's son actually came down to the ED to find us. and they went up to the OR and brought this and showed them, they're kind of dubious, as you can see right there, but showed them where it was, and they said, okay, we'll go back in and fix it. But while you're here, would you mind seeing this patient on the floor? We can't really manage to do her paracentesis, and could you help us with your ultrasound? So, people that were sort of resistant to the change became sort of fans very quickly. This is the same resident giving lectures to the internal medicine staff on cardiac markers, because they're still using LDH to diagnose ACS and STEMI. So just trying to educate and change in practice and all that. And this is her teaching one of the residents to do a chest tube. One of our residents has a blog who's there right now, and talking about ways to think around what you have available to you. He had a patient who came in with a beta blocker overdose. And so this is something that's fairly straightforward to treat when we're here. You order your glucagon and, plus or minus interlipid and all this, and we'll intubate him if the airway wasn't great, but they of course had no glucagon in the hospital, don't even think about interlipid. And their students in this hospital both were in use. So if this person needed to be intubated, he was going to be bagged for days until one of the vents became available. And so he's just pacing around the ED trying to figure out what to do for this person who is slowly deteriorating, and he found salbutamol, which is a beta agonist. He's never heard about using this with it, but was like, just give it a shot because this guy's dying. And he improved, and his blood pressure came up, and his mental status improved, and that's a skill that, he's not going to use salbutamol to treat a beta blocker overdose when he comes back, but the fact that, learning how to think on your feet, learning how to make your own decisions for the benefit of the patient is something that he will carry with him, and he'll be able to teach, when he goes on. So, anyway. And this is ways that, best practices as well, things that, ways in which care is made available that we don't do that maybe we could learn a little bit from, but asthma is terrible there, just terrible. People die of asthma on a regular basis. They come in extremis, and like I mentioned, aren't a lot of ventilators to be had. And in terms of maintenance medications, some people can get them, some people can't. So this is a little asthma station that's set up. They have at the beginning of every ED in Fiji, but this is before triage. Like, this is kind of out by the parking lot. Nobody checks in. So they just have a nebulizer running and little aliquots there of salbutamol, and you just feel a little short of breath. You come and hang out, breathe until you feel like you can breathe again, and get back in the taxi and leave. And so otherwise their ED would be overwhelmed with these people, and they'd be waiting so long for care that you'd have more people that needed urgent care. So I thought this was a nice way of just making care, and access to care, and affordable without sort of all the restrictions that we put on everything here, right? We've also, in ED, we see people all the time who have waited, 14 hours for something that, if you'd known they were out there, it would take, 2.5 minutes to take care of. And what does that cost in terms of them missing work, in terms of, our resources, and it takes them longer to be checked in and documented and all this stuff than you providing the care. So it was nice that some of this works more smoothly. And this is one of my favorite billboards. You can see that you also get the ID exposure as well in Fiji. And this to me is just an example of how there's room for every specialty in global health. So, like we mentioned surgery, we mentioned emergency medicine, all this stuff, but also PM&R, public health, all of this. This is a woman and her daughter who has her hand on her head, and she had some sort of muscular degenerative, undiagnosed condition. And her daughter, who's holding her head, had been in nursing school, and family is extremely poor and has very little resources. And this was a great thing that his daughter was going to be a nurse and going to be able to really improve her family's quality of living. But she had to quit nursing school because what she does now is hold up her mom's head. Her mom can't hold up her head, and there's nobody else to help her hold up her head, and her mom would sit there and not be able to eat all day and not be able to function, and so that's just what she does instead of becoming a nurse. And so this happens a lot after strokes as well. Even if a stroke comes in out of the window and there's no way to treat it, there's no rehabilitation, there's no learning how to walk again, there's no learning how, there's nothing unless your family can intuit something and figure it out. You are out of luck. And so the productivity that is lost from that is just astounding. And there's just an across the board need for things like this. So just, kids there are really cute. And it's not a bad place to work. So on your day off, you can sit some at the beach and all that. So anyway, that's what we have going at UT in the emergency medicine program. If you guys have any questions, I'd love to answer them. But and we'd love to have anybody come rotate with us. Or any questions? Yeah, what's up?
Thank you for that nice presentation. So my question is about, there's been a lot of thought about with these exchange programs, getting the doctors there or medical workers there
Mm-hmm.
to come observe here. And you mentioned having these really ambitious doctors in Fiji that,
Mm-hmm.
that seem really motivated and were trying to make changes in their hospital after you were teaching them.
Sure.
So have you thought at all about bringing any of them over here to observe and get probably a wealth of new information and ideas that they could take back?
Absolutely. So one of the goals of the program over there, it's also a 3-year program, is that they're going to sit for either the Australian or the American steps. I can't remember what it's called in Australia, but the equivalent of the USMLE, and that that their last year in residency could be an intern year in either US or Australia, and the fact that hopefully with the training they've got there, they become a much more, foreign grads have it tough all around, right? And so the fact that they've done this residency already in conjunction with, some Western training as well, and the fact that if they do well on their boards, that will make them much more attractive candidates, and that we're hoping that some of them will do that as well, and then hopefully come back and practice in Fiji. But that's also, emergency medicine doctor there makes like 10,000 US a year, which, is just, it's not a lot of money. It's even in Fiji, so.
What are the funding sources for the 2 hospitals involved? How do you get those additional funding? Is that
It would, actually. So the Fiji healthcare is nationalized. And so the government does pay for these hospitals. The challenge is, EM is sort of upstart there, and so is quality sort of an approach, and so is academic. So there is a lot of, well, I learned it this way 30 years ago in this whatever medical school, and so this is how we're going to do it, and this is how it is. And so kind of that culture over here of like quality improvement and all that has not gotten there. And so, people were giving IV Lasix for asthma. We couldn't really figure out why. Physiologically, we just couldn't figure where that came from. And I don't know if somebody had read about nebulized Lasix or what, but I was just but that's just what you do. And so nobody was thinking about why you do it. And so it's sort of a training about how you think about all of that. But anyway, so it's convincing. It's a large process. It's kind of a bureaucratic challenge, is to convince the people you work with that this is valid, that, if you got ill, if your children got ill, you would want to be able to bring them to an emergency room where you would get decent care. And, where the hospital would have decent care, and to get everybody on the same board and working together, as everybody's been kind of working separate. So it's really about changing the culture of medicine there, which is challenging, as opposed to, because it's already started a little bit and it's just gone on a different path. Burma is, it used to be a Doctors Without Borders hospital years ago. They built the original structure, and we're just starting up there as well. So, I'm going there in May, and the goal is sort of a needs assessment to see what we need in terms of more infrastructure and supplies and all that. So there are different relief agencies for the Mon people, but they, are very poor, and they're running refugee camps and all that. So that is the current challenge right now for Burma, for sure. If you have any ideas, I'd love to hear them. Yeah.
I'm just kind of curious. I didn't hear exactly. I missed the very open. I didn't hear how long y'all been doing this for, but I'm kind of curious. Have you looked at residents who go there and come back? Have you looked at sort of their ordering practices or their? I know you're saying they're learning a lot more skills and other
so, I mean, a lot of that for us is anecdotal. Our programs have been going on for about 2 years. So it's a really new program. I mean, there have been studies done showing that people have more of an awareness in terms of cost and resource utilization. We have not done that research, and it's kind of difficult to track in our current EMR, but it would be something we would really like to look at, for sure. It's anecdotal. I don't know if they're saying it because they know we like to hear it, but. Anything else? Okay, thanks guys.